Okay. Good morning, everyone. I'm Dr. Lee. Today we are talking about Piriformis Syndrome. So it's a clinical condition where the sciatic nerve get entrapment at level of ischial tuberosity. So several articles define it as peripheral neuritis of the branch of sciatic nerve where due to the condition happen to the piriformis muscle. So this condition happens usually more to women at the middle age, with the ratio women to men 6:1 most likely explained by because the wider Q angle at the woman. So it also often seen in patients with having long distance driver or bikers or skiers So how it happens is usually the etiology can be divided into primary or secondary, which the primary one is more to anatomical causes. In normal population, mostly the sciatic nerve will pass through the piriformis muscle posteriorly. But in certain variations, such as certain variation, the sciatic nerve will just either go through the piriformis muscle or anteriorly to that. So, with this the anomalies of the anatomical variation, it might prone patient to having this Piriformis syndrome. The secondary causes is precipitatory causes or is trauma causes So whether it's a trauma towards the buttock region, hip region, or having a surgery like hip displacement, or some patient had a history of hip dislocation and so on. Other cause is like microtrauma as well, which is a patient overuse the piriformis muscle. Certain condition like having abnormal biomechanics during walking or doing certain work. So when the piriformis muscle is overused. So the symptom typically patient presented with hip and buttock pain at the affected site, that especially with paresthesia and pain radiating to the posterior thigh. So this article confirmed that there's should be quartet of a symptom to in Piriformis syndrome. So where there should be one, there should be a buttock pain. Second, the pain is aggravated by sitting. Third is should be external tenderness at the greater sciatic notch during palpation. And fourth is the pain is elicited when there is a maneuver that increase the tension of the piriformis muscle. So one thing to remember is that the neurological deficit is not a characteristic in piriformis muscle, unlike in lumbar spine pathology with nerve root entrapment. So when we examine the patient, usually, like we mentioned before, there will be tenderness at the greater sciatic notch. So we might see patient having a gluteal atrophy and a positive triangular sign, which could be contribute piriformis muscle overuse that causing the piriformis muscle. So other sign like there could be a positive straight leg test, and also painful when we are doing the active or passive piriformis test, where we put tension on the piriformis muscle in certain position, like adduction, internal rotation, and flexion of the hip. So there are certain other signs like pace sign, which patient need to resist abduction of the hip, and axial rotation, patient will feel pain. And then Freiberg sign, where we internal rotated the hip when patient in supine position. Fair test, where we elicit the pain in where we stretch the piriformis muscle. So the differential diagnosis is quite wide, because there's a lot of pathological can happen presented with hip pain. So most common is the lumbar spine pathology, like PID, spondylosis, especially when there's a condition where there's nerve entrapment. There could be a problem with the SI joint, like SI joint dysfunction. There could be problem from the hip, such as labrum injury, hip OA, femoral FAI. So the investigation wise in imaging, such as X-ray, CT, rarely have a role in diagnosing the piriformis muscle, Piriformis syndrome, but they could be useful, mainly useful in to rule out other conditions, like mentioned before, like in spine, pelvis bone, or the hip joint. So EMG would be beneficial when when we notice abnormality in imaging from the EMG, where if the abnormal is noticed in muscle above proximal to the piriformis muscle, it could be because of the lumbar spine pathology. Whereas if those are normal, and then those in abnormal is then the muscle seen in the muscle distal to the piriformis muscle, then it could suggest this is a piriformis muscle syndrome. So injection towards the piriformis muscle, it could be diagnostic and therapeutic as well. So injections such as steroid, LA, and also Botox. So how we manage the patient, it could be mainly conservative, either pharmacological and non-pharmacological. Pharmacological with like painkillers such as NSAID, neurobion, and muscle relaxant such as Mional. Injection, like we mentioned before, it can be therapeutic as well. Then physical therapy could be helpful. Mainly we can either physiotherapy with ultrasound or PEX to relieve the pain, and then we ask patient to do his hip strengthening exercises and stretching of the piriformis muscle. So patient will be re-evaluated few months later. If the symptom is persistent, then patient might need surgical intervention such as piriformis muscle tendon, what is that? The piriformis tendon tenotomy. So to evaluate the outcome of the treatment, we can use the Roland Morris disability score, the questionnaire. So I end my presentation today.